Good day everyone, I am Michael, moderator for this webinar. I welcome everyone for today's webinar, which is Physician Billing for Incidental and Shared Care Services. It's a great pleasure for me to introduce our presenter for today, Jen Rasmussen. Jen Rasmussen, PCS, ACS, OB, ACS, GI. As a healthcare consultant, Jen has more than 45 years of experience in physician billing, reimbursement, and compliance. I would now like to hand over the floor to the speaker. Over to you, Jen.
Welcome, everyone. Today we're going to look at Incident 2 and shared care billing. They continue to have problems sometimes in the realm of coding and guidelines because there's been changes through the years and rather frequently there's been some updates. So what are we going to do today? We want to define who QHP providers are. We want to identify clinical staff providers and services they can provide. We're going to look at what services require orders. That's one of the things I find a problem with in my auditing. Explore the differences between Incident 2 and shared care services. They are different animals. Review specific guidelines for each of these services and understand the reimbursement issues associated with these services. And last of all, look at how other payers view these Medicare policies. What are the basics? Well, any physician group that employs QHPs may be faced with billing Medicare for their services. If you don't follow the Incident 2 or shared care guidelines, you have, what is a QHP? Well, QHP is the current name for NPPs, non-physician practitioners. QHP is Qualified Healthcare Practitioner. The NPP supervision scope of practice, or QHP scope of practice, can vary by state. Some states specifically limit the type of services that an NPP or QHP can provide. Now, PA supervision scope of practice. Scope of practice determined by the supervising or the collaborating physician at the practice site, and sometimes they have limited prescribing authority. On your screen right now below is a website to check by state for PAs, physician assistants supervision guidelines. What is the difference between a QHP and nurse practitioner or physician assistant? A clinical staff person is one that works under the supervision of a physician or a QHP professional. Clinical staff services, some of the things they can do, obviously, is a 99211, which is your lowest level E&M service for an established patient. What about supervision? Supervision requirements for diagnostic tests or other services. Okay, Incident 2 are services that can only be performed in a physician office. If auxiliary personnel perform services outside the office setting, i.e. in a patient's home, other than hospital or skilled nursing facility, there has to be direct supervision by the physician. In other words, he has to be at that patient's home when that auxiliary personnel is performing the service. In 2023, the physician fee schedule, final rule, revised the requirements for general supervision for behavioral health services. Public health emergency temporarily changed direct supervision rules to allow that supervising professional to be remote. Incident 2 rules do not apply to a new patient or a patient that has a new problem or injury. Incident 2 do not apply if there's a change of plan of care. Both the credentialed physician and the NPP, QHP staff providing the Incident 2 must be employed by the group entity billing for the service. Documentation. What do you need to have documented? Okay, here's some scenarios I want you to think about. Second scenario, Medicare patient seen by nurse practitioner for annual physical. Let's talk about shared care. Whole different animal. Shared or split services are E&M services performed between both a physician and a non-physician practitioner or QHP in the same group in a facility setting only. The QHP is employed in the same group practice by the physician or employed by the same employer. CMS states the service should be reported by the clinician who performs the substantive portion of the visit. Activities that can be considered part of time for substantive portion. Activities that cannot be considered when billing based on time. For all split and shared care visits, one of the practitioners have to have a face-to-face with a patient. If the QHP documents the history and exam and a portion of the medical decision-making, the service may be billed under the QHP. Substantive portion based on time is the one that spent 50% or more of the time on the same data service. Time is not a factor in the ER setting, unfortunately. The individual who performed the substantive portion of the service must be the individual that signs and dates the medical record. Split shared care can be reported in any facility setting, inpatient, observation. Critical care. Well, it's pretty clear that critical care is based solely on time. Prolonged attendance can only be based on services where the documentation is based on time. So the physician and QHP will add time together, and whoever furnished more than half of the total time, including prolonged time, will report both the primary service code and the prolonged service add-on code. Split shared care must be reported with modifier FS. What about commercial payers? Some may specifically exclude Incident 2. UHC allows Incident 2 and shared care. I'm very glad you were able to come today. Hopefully we'll give you all the answers you need. Thank you all for coming.
Thank you, Joan. That does conclude the session for today. Thank you everyone for participating. You may all disconnect now. Have a great day ahead. Bye-bye.